quickly now. It's a great privilege to be back into the sessions on the grand rounds for cardiology. My name is Partho Sengupta. All of us have gone through this in the last season, and it was very well received. Thank you, everyone, for joining. For this season, as you know, that we have made small modifications, and I'm going to share my screen to show you what we have in store for today. So a few housekeeping items. First of all, we are having the cardiology grand rounds continued on the YouTube website. So this web link offers you the list to not only the old website and the recorded grand rounds, but also the incoming links will be posted here. And as you would know, that the few modifications that we did was we tried to balance the time so that people can join in, and we decided to do 5:30 to 6:30 p.m. And again, we are continuing with the same theme, from practice to perfection. And we have had confirmation from a very large group of distinguished faculty from different institutions who are going to be giving the grand rounds. And there will be some more updates and some more exciting talks that will be created from time to time. But this is the list of people who have confirmed their acceptance for the grand rounds. And for the CME and the MOC credits that are provided, we do have the CME and the MOC credits starting today. So at this moment, please text 14276 to the number 888-816-4893. And you can do this anytime within the next 12 hours. It's an SMS message, provided you have an active profile. And please have your mobile phone also identified with your profile in the Rutgers CME credit place. For the MOC points, and this is for only physicians, please complete your step 1, and you can go to this web link, and this web link will be also posted subsequently in middle of the presentations, and you will use a room code future24. And once you have correctly identified the answer, you will be getting the credit MOC directly into your ABIM website, provided your ABIM ID is identified with your Cloud CME profile. So with that, we come today to our grand rounds for today. And I'm really thrilled and honored to welcome not just our grand round speaker, but he's now our own faculty. And it's just been a great privilege and honor for us to have Dr. Sabahat Bokhari join us. And he has just joined recently this month on September 6th. A little bit about him. First of all, I would say that he's one of the most humble, mild-mannered gentlemen I have seen as physicians, and I think he's a role model for all the fellows and faculty, I would also say. And I really enjoyed interacting with him. And anybody you talk to in national societies speaks high volume, not only about his caliber and his research that he has done in the field, but also for the way he comes and attends as a physician, as a colleague. His professionalism is par excellence. Dr. Bokhari originated from Lahore in Pakistan, University of Punjab, where he did his internal medicine and residency, and subsequently also completed his cardiology fellowship in Lahore, and then went to Royal Brompton in United Kingdom. And subsequently, actually, he was in so-called at that time UMDNJ, Robert Wood Johnson Medical School, St. Peter's University Hospital, where he did his internship and residency. And after completing his internal medicine, he went to Columbia University as a fellow in cardiology, and also did the advanced cardiac imaging fellowship. Subsequently, he rose to prominence as the director of nuclear cardiology and advanced cardiac imaging uh, at Columbia, where he was there for 12 years. And he was instrumental in creating several new paradigms in cardiac PET. He was also instrumental in creating the Advanced Cardiac Imaging Fellowship Program. And these programs really have attracted top-notch cardiology trainees from all over the country. And it's a great pride for us that he is also going to become the Advanced Cardiac Imaging Fellowship Director for us. And also he's going to be the Advanced Cardiac Imaging Specialist Director of the Cardiac Imaging Program, which will include not only nuclear cardiology and in near future expansion to PET, but also there's a commitment from the health system for the MRI and CT to be led by him. He's also going to be the director for the cardiac amyloid program. And this will be the first cardiac amyloid program in New Jersey. And this is really exciting. After he had done his cardiology and before he has joined here, he was in Lehigh Valley Hospital Vascular Institute, and he was the director of cardiac imaging and the cardiac amyloid program, where he worked very closely with the radiology department and really created a tertiary high caliber referral cardiac amyloid program that spanned the entire network. And all his patients apparently are going to follow up and come here into the cardiac amyloid program, and that we will form here at New Brunswick. And his expertise, not only in cardiac imaging, but also in cardiac amyloid is well known nationally and internationally. He actually pioneered and developed the so-called PYP scan that you all use right now. So he's been the person behind the evolution of the entire imaging in cardiac amyloidosis. He has widely contributed to not only the science in cardiac imaging and cardiac amyloidosis, but he's well known for his contribution to guidelines and consensus statements on not only these avenues, but also stress testing. And he has he's been a principal investigator for over 30 trials, clinical trials, and he's been co-authoring over 100 manuscripts and textbook chapters, and also written in the Brownwell's heart disease. So with these words, I'm going to invite him to give his talk on the bright side of cardiac amyloidosis and what he foresees is going to be the bright spot of cardiology also at New Brunswick. And after he gives his presentation, we will be having a panel discussion where Dr. Danielle Moin and Dr. Dinesh Singhal will join us. And obviously, I think there will be lots of questions that might come up. So please feel free to have your questions jotted down. If we don't complete them in this 1 hour time, we'll try to make sure that we come back and have them answered, because I think the excitement is just rising and it's palpable. With that, Savi, the floor is yours.
Thank you very much for such a kind introduction. Let me just open it up. Come on. All right. I'll try to go fast through the slides because I have too many slides. So the objectives are to go over an overview of cardiac amyloidosis, and also to discuss what should prompt suspicion of ATTR cardiac amyloidosis and how suspicion can be confirmed through diagnostic techniques, and then to review the treatment options for ATTR-CM. So the journey from Rudolf Virchow to silencer. So Rudolf Virchow in 1854 coined this name amyloid And that was based on the finding which we saw on microscopy, and thought that that was a starch, because amyloid in Greek means starch. And he named it amyloid. And then later we found out it's really not starch, it's a protein. So it really started, the journey started in 1854. Then in 1952, from Portugal, the Portuguese physician reported in 1952 that familial amyloid polyneuropathy was likely due to amyloid deposition. And then in 1962, about a decade later, Fredrickson reported that this could affect heart also, and he reported a case series in which the patients had heart involvement. So what is the cardiac amyloidosis? There are many types of cardiac amyloidosis, but the two most common types, which accounts for more than 95% of all cardiac amyloidosis, are immunoglobulin light chain amyloidosis and ATTR amyloidosis. Immunoglobulin light chain is produced by plasma cells, and these immunoglobulin become unstable and form misfolded proteins, and then that causes formation of amyloid fibrils. AL amyloidosis typically presents in patients over 50 years of age, and it can be distinguished from other types of amyloidosis through various testing methods. Median survival of untreated patients with AL amyloidosis with cardiac involvement is less than 6 months. So it's considered a medical emergency. It is important to rule out AL amyloidosis as the treatment regimen is very different from that of ATTR. So in this talk, we are just going to concentrate on ATTR cardiac myopathy. So ATTR is transthyretin, which is a transporter protein produced by the liver, and it transports thyroxine and retinol, hence the name transthyretin. It's in a form of a tetramer, and once the tetramer becomes unstable and forms monomers, and then those monomers form amyloid fibers, which are deposited in the extracellular space and causes dysfunction of the organs. And it's most commonly involved the heart and the nerves. There are two types of ATTR cardiac amyloidosis, and the one which is wild type, and the other one is called hereditary type. In the past, we used to call it senile and mutant, but those so wild type and hereditary are much better names than those two names. So wild type and hereditary. Hereditary is then divided into three different types. One is a cardiomyopathy phenotype, and one is a mixed phenotype, and the third one is a neuropathy phenotype. The one which is a cardiomyopathy phenotype, the most common mutation in the United States for that is V122I. That's 4% of African Americans have that mutation. And the one which is worldwide, the most common mutation is V30MET. And those are divided into two, early onset and late onset. Early onset only involves the nerves and causes a debilitating neuropathy, which later on, in fact, leads to death. And the mixed phenotype is the one which is late onset. It's around 60 years of age, and that has both neuropathy and cardiomyopathy. And then the third most common is ALA60 mutation, which is a common mutation in Irish descent people, especially people from Northwestern Ireland, from Donegal area. About 1% of the population carries that mutation. So here's just showing you the different mutations, and there are about a total of 120 mutations, and the most common mutations which cause this, there are about 9 mutations which cause cardiac involvement. So ATTR cardiomyopathy is frequently misdiagnosed, and delayed diagnosis can lead to significant consequences for patients. Phenotypic heterogeneity and fragmented knowledge of the disease are two of the primary causes of misdiagnosis. The disease is associated with high levels of impairment, including in physical health, quality of life, and reduced productivity. Once diagnosed, untreated patients have a median survival of 2 to 3.5 years. It's about 2.5 years in hereditary ATTR, and it's about 3 to 3.5 years in wild type ATTR. Most of these patients, it takes them close to 9 months to a year before they are diagnosed. And it takes them about 5 physicians, and including about 2 cardiologists before the diagnosis is made. And overall, about 25% of the patients with AL amyloidosis die within 6 months of diagnosis. And about 25% of the patients with ATTR amyloidosis die within 24 months of diagnosis. So it's really very important to diagnose this disease early and diagnose it so that it can be treated early, because the maximum benefit of treatment is in the early disease. So it's important to look for clinical clues in this disease. And so how to unravel the red flags of cardiac amyloidosis? I think it's important for cardiologists to put the internist hat for this, because this disease involves multiple systems. And you have to look for infiltration, which is hidden within the hypertrophy of the heart, which is hidden in the nerves with neuropathy and autonomic neuropathy. And also look for the rhythm of the disease, because every disease has its own rhythm, and amyloidosis has its own rhythm. So, and look for discrepancies. So what's the prevalence or incidence of this disease? AL amyloidosis is a rare disease. There are about 10 per million patients, and there are about total 3,300 cases per year, and only half of them have cardiac involvement. So this is a rare disease. ATTR, which is hereditary type, as we said, that 4% of African Americans are carriers for this mutation, which is BEL 122I. And there are about 25,000 to 120,000 US patients, or probably more than that. So it's not so rare. The one which is ATTR wild type disease is about 25% of the adults who, after on autopsy of their hearts, died over 80 years of age. 25% of those patients had ATTR in their hearts. So that's about 250K to 1 million. So it's not rare. So how does the cardiac amyloidosis present? So first, we look for clinical presentation, then there are biomarkers, then there are ECG changes, and then echo, and then cardiac MRI, and then last for diagnosis is nuclear imaging. So the amyloidosis has different presentations. So the cardiovascular presentation are mostly heart failure, and most common is the HFpEF in these patients. And other thing is you see a patient, older patient comes to you who was taking 3 or 4 blood pressure medications, and now he's down to 1 or 2. So there is de-escalation of his blood pressure medication. And that's a very common thing you're going to see with this amyloidosis patients. They are intolerant to especially ACE inhibitors and ARBs. The other thing is low voltage relative to LV wall thickness. And echo would show increased wall thickness, LV wall thickness, and then there'll be conduction abnormalities, and also atrial fibrillation and other arrhythmias, which are very common with cardiac amyloidosis. And then aortic stenosis. About 22% of males who go for TAVR have aortic stenosis, and 3% of females. Overall, 16% of the patients going for TAVR have aortic stenosis. The nervous system involvement, so peripheral nervous system and autonomic. Most of these patients will have autonomic neuropathy. So we'll have lightheadedness, dizziness because of autonomic neuropathy, GI symptoms, orthostatic hypotension, sexual impotence, and also we'll have peripheral neuropathy, especially in hereditary ATTR. Other thing which is important is vitreous opacities. I usually send my patients once a year for their eye exam for vitreous opacities who have ATTR cardiomyopathy. Other thing is musculoskeletal or orthopedic, carpal tunnel syndrome, lumbar spinal stenosis, distal tendon of the bicep rupture, and then hip and knee arthroplasty. Renal involvement is more common in AL amyloidosis, but it also occurs in patients with wild type ATTR. So the first thing which is important is the carpal tunnel syndrome precedes cardiac involvement by 5 to 9 years. So if you can diagnose these patients when they are getting these bilateral carpal tunnel syndrome or have carpal tunnel syndrome, especially patients with LVH, you can really screen these patients early and treat these patients early so they would not have more morbidity because of amyloidosis. And then the next is neuropathies, and then all the cardiac symptoms, and then the fatigue. So here, it's important to look at this slide. If you look at total heart failure patients with preserved ejection fraction, there have been multiple studies, ranges anywhere from 12% to 17% of HFpEF patients who have ATTR cardiomyopathy or ATTR cardiac involvement. And there are about 10% HFrEF or or mid-range heart failure EF patients who have ATTR cardiac involvement. Then if you look at carpal tunnel surgery, patients who have carpal tunnel, there are about 7 to 10% patients who have bilateral carpal tunnel have ATTR involvement in their synovium. And for hypertrophic cardiomyopathy patient, it ranges from 5 to 7%. I'm not sure if they have, in addition to hypertrophic cardiomyopathy, or the hypertrophic cardiomyopathy was misdiagnosed. They really had amyloidosis. And aortic stenosis we already discussed. So if we take this heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, or total heart failure patient, so it comes to about 22% patients, or if you looking at both these. Now, in Robert Wood Johnson whole health system, there are 200,000 Medicare patients which are checked with Medicare claims. And as we know that 17% of Medicare patients have heart failure. So if you take that 17%, that comes to around 34,000. So out of those 34,000, if you take these 22% of that, so that would come to, just for the heart failure, that would come to over 7,000 patients who have ATTR cardiomyopathy. And when you check it with how many of the patients are right now being treated for ATTR in the system, there are around 100 patients for the whole system. So we have a lot of patients who are not diagnosed and are not on treatment. So after the clinical system, the next thing which is important is looking at biomarkers. So any patients coming in with low grade persistent troponin elevation, you have to think about amyloidosis, patients with elevated NT-proBNP. And the most important thing for all the patients, before you even think about ATTR, you need to rule them out for AL amyloidosis, because that's a medical emergency. Without treatment, their average life is 6 months. So you always check your serum and urine by immunofixation, not SPAP and UPAP. Has to be by immunofixation for monoclonal proteins, and also look for free light chain assays. So for EKG, the next step, so as we are all taught in medical school, low voltage EKG, think about amyloidosis, but only 20% of patients with the TTR have low voltage EKGs. And about 30% of patients with TTR cardiomyopathy have LVH on their EKG. So EKG is helpful low voltage, but if it's not low voltage EKG, that does not rule out amyloidosis. Second thing is looking for pseudo-infarct pattern in inferior and anterior leads, which is in about 70% of the patients. And then conduction abnormality are in about 22% of the patients. Echo, if you look at the top image, you can see some speckled pattern in the myocardium, and LV walls are thick. LV and RV size are normal. Atria are enlarged. And the most important thing whenever you see the amyloid image is you can clearly see the interatrial septum. You can see the valves. And most of the images which you see on the first page of the textbooks, their cover is usually amyloid images because they look so clear and beautiful. Second, you are going to see pericardial effusion in these patients and also see pleural effusion in these patients. Then when you look at the subcostal view, which is the bottom image, you can see the left atrial appendage. Now, this is very common in patients with amyloidosis because their flow velocity of the atrial appendage is usually less than 20. And it's a very high incidence, even without AFib, of left atrial appendage thrombus in these patients. Then we look at the diastolic dysfunction of these patients. Usually their E prime velocity is less than 6. There's steep deceleration time in these patients. Their E to E prime ratio is greater than 11. Their TAPC is usually less than 19. And then the other thing which is important is global longitudinal strain. For these patients, you're going to see the typical image where the apical wall motion is preserved, basal is down, and you see that if cherry on top polar map or the bullseye polar map. So this is suggestive of amyloidosis, but this can also occur in patients with aortic stenosis, hypertension, hypertrophic cardiomyopathy, or in some variants of stress-induced cardiomyopathy. So we look at this increased wall thickness score for the diagnosis of ATTR-CM with echo. So especially when you're doing echoes, there's a different score for AL, and this is for increased wall thickness score is used for TTR amyloidosis. So the next step is cardiac MRI. So in cardiac MRI, if you look at the top image, which is the cine images of the 2-chamber, 4-chamber, and short axis. And you can see that wall is thick, atria is mildly enlarged, there's pericardial effusion, pleural effusion. And then when we look at the late gadolinium enhancement images, which is the bottom row, they have black blood pool. And this arrows which you see, where you see the light uptick there, that's all your late gadolinium enhancement. And that's commonly seen in subendocardial or transmural pattern. And if you look at the 4-chamber view, which is the middle image in the bottom row, you can see that there's a lot of RV involvement. And especially in the septum, you can see a dark band in the septum in the middle. And there's subendocardial enhancement on both sides, on the LV and RV. And this is called a zebra sign, which is present in patients with amyloidosis. And same thing on the short axis, you can clearly see diffuse late gadolinium enhancement. So other thing which we look for is T1 map in these patients. And there's increased T1 in these patients. If you look at your right middle image, you can see these increased T1 on this in AL and also in TTR patient, and which corresponds also with your late gadolinium enhancement, where there's diffuse enhancement over here and diffuse enhancement here with black blood pool. So whenever you see an image on late gadolinium enhancement, which looks like a bad image, and sometimes people will say it's a technically poor late gadolinium enhancement study, think about amyloidosis in those patients. Other thing which is very important with amyloidosis is ECV. We monitor the disease with this ECV in patients to see if their disease is progressing or if they're getting better with the treatment. And that's usually you take your pre-contrast T1 map and hematocrit and then post-contrast T1 map. And you calculate your ECV, which is the extracellular volume. And it is strongly correlated with the amyloid deposits and fibrosis. So now we come down to the clinical applications of PYP imaging in suspected cardiac amyloidosis. So their tracers only concentrate on the tracers which are clinically used now. PYP is used in US, HMDP is used in France and Sweden, and also DPD is used in rest of the European countries. So in early 80s, there were some case reports that PYP can be used to diagnose amyloidosis non-invasively. Then in the late 1980s, there's a case series which came out and said that this was a used as test because the sensitivity was about 30%. Then it was resurrected in 2005, the DPD imaging, which is another tracer, which is in Europe. And Perugini basically reported that in few patients, he had only 25 patients, 10 in AL, cardiac amyloidosis, 15 TTR. And he showed this isotope was 100% sensitive and 100% specific in diagnosing ATTR cardiac amyloidosis. So based on that paper, I wrote to FDA asking them if I could use that tracer over here in US, and they said no, because it's not approved in US, so we had to go through the whole preclinical and clinical studies. So we looked at the isotopes and we thought PYP was closest to DPD, and also it was readily available in US, was approved for blood pool imaging and was approved for also cardiac imaging for detection of acute MI, which we used to use in 1970s before troponins, and bone imaging. So in the top is the DPD protocol, so which was a long protocol, and it's required because it's a whole body imaging, and it requires a nuclear medicine physician to read these studies. So we designed a protocol in which it would be just the chest, so any cardiologist can do it as in the outpatient setting, the scan and read it, so that they don't have to send the patients to hospitals, and also do not have to have a nuclear medicine physician to read these studies. So the bottom one is the protocol which I designed, and the top one is the one which is done in Europe. And we now do this protocol with the PYP. I'm not going to go in detail of the protocol because of the time. So basically, it's a simple, for reading, it's very simple. You look at the visual assessment, you always read it in the lateral view, and you basically see if there's any uptick in the heart, which on the left, there is no uptick in the heart. And you see if the uptick is less than ribs, score is 1, equal to ribs 2, greater than rib is 3. And if any score of greater than 2 is considered positive for ATTR amyloidosis. And the first thing, remember, it's only positive for ATTR amyloidosis if AL amyloidosis has been ruled out. So this was the study which we published in 2013, the first study for PYP, in which we had 45 patients. And we saw that this was 97% sensitive and 100% specific. And there was one outlier, and that outlier was a rare mutation, which is a type B amyloid fiber mutation, which are usually negative for PYP imaging. So in this, what we look at is the heart to contralateral ratio and the visual score. So visual score, just to confirm if the visual score is correct or not, we use heart to contralateral ratio on top of that. And we always do SPECT imaging with that to basically helps to differentiate that uptick in the cardiac region if it's a blood pool or myocardial uptick. And we do 1 hour or 3 hour imaging, but it's much better to stick with 3 hour imaging because most of the blood pool clears up by 3 hour imaging. And the cutoff which is used for heart to contralateral ratio is 1.3 for 3 hour imaging and 1.5 for 1 hour imaging. You can also do your visual score on your SPECT imaging, but usually SPECT imaging, it's hard if you do not have a SPECT CT for doing that visual scoring, because especially if you have no uptake in the myocardium, then it's hard to find out where the heart is. Now, when you're reading your SPECT CT, if you have that, you can read it in transaxial or you can read it in coronal. And now we have moved ahead and we are doing quantification and looking for, especially in the new cameras with new software with SPECT CT, you can get your SUVs and quantify the uptake. So then later we did a multi-center study and found out there was also prognostic significance of heart to contralateral ratio. If the heart to contralateral ratio was less than 1.6, so these patients did better than the patients who had heart to contralateral ratio greater than 1.6. So with all this data, so 9 of the centers of amyloidosis, we got together, we put all our data together and looked at the sensitivity and specificity of this test. And we found the sensitivity was 100%. Specificity was about 86% if we had not ruled out AL amyloidosis. But if we ruled out AL amyloidosis, specificity was also 100%. Based on that, then the consensus statement came out, and this is now what is part of the guidelines, is that if you have any clinical or imaging suspicion of amyloidosis or with biomarkers, you do bone scintigraphy and you get this different score. Also do the serum and urine immunofixation for monoclonal proteins and free light chain assays. And if your bone scintigraphy is negative, that means there's no uptake, and your serum and urine are negative for monoclonal proteins, you do not have amyloidosis. If your bone scintigraphy is positive, grade 2 or greater, and there is no urine or serum monoclonal proteins, then you have ATTR amyloidosis. And the next step would be doing genotyping. The ones who are in the middle, the gray zone, grade 1, in those patients, or the patients who have positive urine and serum for monoclonal proteins, in those patients, you move ahead with biopsy. So in US, what we noticed was 30% of the patients were just going for PYP imaging and no one was checking urine and serum for monoclonal proteins. So we modified the protocol and the guidelines. And what we said was it's much better to do urine and serum first. If they are negative, then go for bone scintigraphy. If they are positive, you have a completely separate arm, you go for biopsy, either fat pad or bone marrow biopsy. So the biopsy is good for AL cardiac amyloidosis, fat pad and bone marrow, but has a very low yield for TTR, especially fat pad and bone marrow. So if you're suspecting ATTR cardiac amyloidosis, you go for endomyocardial biopsy. So then what we noticed was a lot of people started doing a lot of unnecessary PYP imaging, and that brings the specificity down. So then we came out with this, that which patients should be screened with PYP. And so these are, I'm not going to go because of the time shortage with all these. So these are all published. You guys can take a look at it. So which are the red flags which should be looked at. And so just easy way is any male over 65 or even female over 65 has LVH of greater than 14 millimeter, and any of these other features, you need to screen those patients. And remember, screening includes not only PYP, but also serum and urine for monoclonal proteins by immunofixation and free light chain assays. So we go to treatment. So I think it's a very exciting time for amyloidosis right now, because we have now treatments available. So if we start, in the past, we only had liver transplantation for TTR, and really not much, but now we have gene editing and also gene silencers. So gene editing is right now in just early clinical trials, which I think it looks very promising, which is the CRISPR thing, that technology. But for gene silencer, patisiran, their trial was just announced a few weeks ago, and was positive trial for cardiomyopathy, and they're applying for NDA for approval to FDA. And then inotersen, these right now they are approved both for neuropathy, but patisiran is applying for NDA for cardiomyopathy also. And then the patisiran's, I would say, daughter compound is patisiran, which is sub-Q every 3 months, which would be really good. And they are right now in clinical trials for cardiomyopathy and neuropathy. And for inotersen is eflornithine. And then we come down to stabilizers from silencers. So stabilizers, tafamidis is the only one which is approved. And then diflunisal is off-label. And then acromidis is in trials right now. And so what it stabilizes the tetramer, so there's no dimers or monomers, and blocks that. And then the other one are reabsorbers, which you can see at the bottom of this figure, which is elimination of deposits. Right now, we off-label use doxycycline and TUDCA, and also then there are some monoclonal antibodies which are being tested. So for treatment algorithm, you're going to treat your heart failure in these patients. You have to be very careful with your ACE inhibitor, ARB and ARNI, and beta blocker. Most of my patients are on loop diuretics, and if I need to, I will add, and some of the patients are not responding, I'll add a little bit of metolazone. And others, I'm treating them with aldosterone antagonist if they can tolerate it. And then also SGLT2 inhibitors. And for disease modifying, you have for cardiomyopathy, it's tafamidis, and patients who cannot afford tafamidis and they can tolerate diflunisal, I put them on diflunisal. And patients who have mixed phenotype, I usually put them on patisiran with diflunisal because it's very hard to get the approval for both, for tafamidis and patisiran to treat these patients. For medical therapy for atrial fibrillation, you control your rate with low dose beta blocker. Rhythm control is really hard. They have a very high fail rate for cardioversion and ablation, especially if you're treating them in the later stage of amyloidosis. And they're all on DOACs and warfarin for atrial fibrillation. And you don't follow the CHAD score in these patients. Anyone who has AFib goes on your Eliquis or your other DOACs. Device therapy, pacemaker, always considered CRT or physiological pacing in these patients. If you put the RV pacing, they do worse, their condition worsen. Especially if they have any MR, their condition worsen really rapidly because they're relying on an already low stroke volume. You lose a little bit of that, they get really symptomatic. And ICD is not recommended for primary prevention in these patients, only for secondary prevention. So I'm just going to skip on these because of shortage of time. Tafamidis, as we all know, had excellent results. And after 18 months, you can see the separation in your placebo and tafamidis treated patients for all-cause mortality. And also earlier than that, you see decreased hospitalization and improvement in 6-minute walk test in these patients. So this was published in, so the results were announced in 2018, September, and the FDA approved it in May 2019, tafamidis. So it was a very fast approval for this drug. And now recently it was just published their 6-year follow-up data, and it still shows significant improvement in mortality. So about 5 years or 6 years, there are about 50% mortality in patients who are treated with tafamidis and about 80% who not treated with tafamidis. So I think that with the TRACK trial, there were 3 first times in a trial. The first time medical treatment has been shown to reduce mortality and morbidity in TTR, cardiac amyloidosis. First time medical treatment has been shown to reduce mortality and heart failure hospitalization and HFpEF. And first time centrally, that is the medication acting on the myocardium, is effective on hard endpoint rather than peripheral or neurohormonal modulation. So this was an important trial. I'm going to skip this acoramidis, diflunisal, I'm going to skip, and then these are different trials I'm going to skip because of the time. I'm just going to go over some of these prices on these drugs. If you look at tafamidis, costs around $240,000 to $45,000 each year. for the patient treatment. So any false positive study which you're going to have, that's about $1.5 million which you're wasting on that. And compared to that non-selective diflunisal is about $60 per month. Patisiran is altogether included is around $450,000. So if you're going to put your patient on a combination therapy, that's about $700,000 a year. So very hard for any payer to approve that. And same thing with inotersen. The price is really very high. So just in summary, very important, always before you order a PYP, rule out AL amyloidosis. And once the PYP scan is positive, you need to get genotyping to make sure if it's ATTR wild type or ATTR hereditary type. Very important. Other thing which I would like to really stress on is that PYP scans or the images, 30% of the studies which are done, even in the centers which have been doing this for many years, are read wrong. They are either false positive. Most of them, the biggest problem is false negative, but we also see a lot of false negatives. Most of them which are read as positive, they're usually not positive, it's blood pool or something else. So it's very important that your technologist and the physicians who are reading it should be trained in how to read it. And we ran a course at Columbia, we ran a course at Lehigh Valley where we trained the technologists and the physicians who were reading it. It's half-a-day course. We did about 75 to 100 cases so that everyone who's reading it, is reading it the right way. Thank you for listening, and I'll be happy to answer any questions.
Thank you very much, Sabi. This was very quick, but very extensively covered. And I think this is exciting. And let me, perhaps if you can unshare your slide set, then we can have our panelists back. And then we can now invite Dr. Danielle Moyne and also Dr. Dinesh Singhal. We can have both of them as our panelists. And thanks for joining, Danielle and Dinesh. So I think I'm going to start with a question to Dr. Singhal. So Dr. Singhal, what do you think is, Dr. Bukhari made a projection that we are probably under treating and not diagnosed, and based upon his projection, I think almost 1 in 6 or 1 in 7 heart failure with preserved patient that I must have seen, I must have missed, not diagnosed the amyloid that was there. What do you think is, is this a call for us to wake up and start doing something novel here in New Brunswick? What are your thoughts?
Well, first, I am so excited to have Dr. Bukhari as part of the faculty here. I've known him for a very, very long time, and I can't tell you how happy I am that he's here with us. So, as I was listening to the slides, and we kind of heard all the clinical presentations which these patients can have between HFpEF, HFrEF, AFib, positive troponins, BNP. That's all we see in the hospital all day long. I mean, that's practically everybody. And then I'm thinking to myself, exactly, the same point you just made. If the statistics show that 22% of HFpEF, HFrEF could have amyloid, but then I'm wondering how many of those, of all those patients have a LV wall thickness more than 14 millimeters. That's really not that often. So so if I'm going to wait, so actually, I'm going to throw this question out in return, and I guess we'll go back to what we need to do. So how do you explain this discrepancy where on the one hand, we have potentially 22% of HFrEF, HFpEF, but I don't think that a good majority of them have the 14. So is this just a continuum of the disease, and therefore would we miss if we are going to wait for that LVH for that degree to show up? How do we kind of pick up those patients who are probably in the earlier of the continuum of the disease process? So I'm going to ask Dr. Bukhari to help me understand that, and then maybe I'll weigh in on what I think we should be doing.
First of all, hi, Dinesh. It's so great to see you after a long time. Really looking forward to working with you. Excellent question. So first of all, to even screen anyone for amyloidosis, they should have some LVH. If they do not have LVH, they probably do not have amyloidosis. Okay, it's really not a true LVH, it's a pseudo hypertrophy because it's in the extracellular space where the amyloid is. So what anyone who is less than 12 millimeter wall thickness and diastolic wall thickness, I would not screen those patients. Anyone greater than 12 millimeter, yes. And especially in female patients, because female patients, I would say, is anyone over 10 millimeter. And if they have any other red flags, I would consider screening those patients. But again, this is not a disease which is that common in women. Second, I would not screen patients who are younger. So the biggest problem which occurs is that when people start screening young females, right? Because this test has a high specificity only because the specificity was done at amyloid centers where everyone who was screened had a very high pretest probability. If you start screening patients with low pretest probability, your specificity is going to go down for the test. And then you will have some false positives who do not have this disease and will be labeled with this disease, will be on medication forever, right? Which is good for Pfizer, but not good for the patient or other people. So I think it's important that we screen. So that the number, what you're stating that 22%, right? So there are only 2 studies for HFrEF, which showed that 10% of those were there. But HFpEF, there are multiple studies now, which range anywhere from 10 to 17% incidence. The one which is the largest study was by Garcia from Spain, in which he had 13% on patients and he only looked at ATTR wild type involvement. So patients who have LVH and have carpal tunnel syndrome, have chronically elevated troponins, have any neuropathy with that, or have lumbar spinal stenosis in older patients, in those patients, I would screen those patients with simple PYP and urine and serum with immunofixation. I think that's where we should start with these heart failure patients.
Thank you. And I'm just going to add this and give it back to you, is that I've been in practice a long time, and I'm pretty sure over the years I've missed a lot of patients. And I think this kind of educational process needs to occur for us to recognize them out in the field. And then I'm not sure we are equipped in an outpatient practice environment to do obviously the management of these patients. So I think both with more recognition and having a robust infrastructure where we can send these patients and they get treatment in a timely fashion is probably how this is going to evolve over time. And I think these are the steps which you're taking is really what is needed in the community here.
So Danielle, if I may interject, so I know with all 3 of you in the advanced heart failure, I'm sure you must have encountered some amyloid, and you have been treating some amyloid. What has been your experience of the hits and how have you been successfully able to diagnose them? What's been your experience, Danielle?
I think a lot of our success is contingent on our referring to identify, and I just got a text from one of our PE doctors who wanted to send an 89-year-old patient we recently diagnosed. So I think a lot of it is really education. We don't, as very specialized heart failure docs, we're not screening patients in the community. So I think an education campaign is vitally important to this. I think what Dr. Bukhari said also about, educating people on the appropriate testing for this. I've certainly seen false positive PYP scans on patients that should never have been tested, who are floridly hypertensive, who had much better reasons to have LVH. So I think really the central issue is just making sure that the people who are ordering echoes and reading echoes have the appropriate, antenna and signal to look for this.
And Danielle, also, I'm sure also you get the end stage cases, and they're very difficult to treat with, fluid responsiveness and diuresis and inotropic. So, they don't behave well once they are reaching to that stage, and you're getting, I think the whole better idea would be not have that stage develop. The stage C and D is perhaps a very late stage and not so good for, but are there any ways we can salvage this patient with, what is in the, how do you manage? I'm not sure I know the latest data on any form of advanced therapies in this subgroup of patients.
Well, salvaging is difficult when you start getting to the point of left ventricular systolic dysfunction. I'm sure Dr. Bukhari can chime in. Prognostically, you're in a tough place. I don't feel like they respond to traditional GDMT. A lot of them are very heart rate dependent because of fixed stroke volume. So beta blockers, essentially cause them to tank. In my fellowship training in Boston, we transplanted some patients who were very good candidates. Outcomes are very challenging. Good outcomes are challenging, particularly in the AL population. You're talking about a stem cell transplant after their heart transplantation. So yeah, when they get more advanced, I think our hands are kind of tied, which is why early recognition is very important.
So coming back to Sabby, so if I may, if suppose you have a patient short of breath, slightly hypertrophy, normal coronaries, the troponins are leaking. You're thinking about, maybe these are the type of the people, because I think what by default we end up getting a non-STEMI diagnosis, and we do see a lot of those patients, and there is a lot of different diagnoses now you can get from non-obstructive coronary artery disease, but many times these troponins may be just coming from amyloid. And there may be a subset of these people in hospital who get discharged, and we never entertain a possibility of amyloid.
Yeah, you're 100% right. So I think the most important thing is awareness. So if you don't have the awareness for the disease, you're not going to look for it. So I think for right now it's the cardiologist, but this should really go up to the primary care physicians, because these patients usually present with multi-system involvement. So they have GI complaints, they have other complaints. So I think it's awareness is number one, and second is that anytime if you know that you have this, these are the things you're going to look for, then you'll find a lot more patients, and also for cardiologists to put on the internist hat. Because most of the time we are only looking for coronary artery disease or other stuff, and we ignore the some of the red flags which are there for these patients. So that is important. It's very important to diagnose these patients early. Later, you can't help them that much, except just some symptomatic treatment, and which is also very hard. Right, because they can't tolerate. They can't tolerate ACE. They can't tolerate ARNI. They cannot tolerate ARBs. And beta blocker, you give them, they usually get worse. I usually start them at a very low dose beta blocker, especially if they have AFib. Otherwise, I usually keep them off of beta blocker. The only medicine which they are really taking is your high dose loop diuretics. Otherwise, really, it's hard to treat them at the later stage. So very important to diagnose them early, and if you diagnose them early, they have a they live a very good life because they won't be that debilitated.
So Sabby, so now let's come back to the practicality. So we're going to create the amyloid center, and the initial tentative plan is to do that clinic in Monroe and develop a multi-speciality clinic there. And of course, we will incubate there. After that, it will probably move to the Plum 2 building. But now let's say you start developing the center. How typically you work with the community and your colleagues around? And how do you manage? How frequently do you see them? Is there a fear that you will take away all the patients or of the HFpEF? How do you, I mean, you've done this very successfully in Lehigh, and everybody is interested. What's your practice been? And can you just educate us?
Sure. So first of all, this is, we only treat amyloid. We do not treat anything else. So any cardiologist who refers the patient to the amyloid center, the patient is theirs and they treat all the other things. So we only treat amyloid, and we make sure that the cardiologist gets all the feedback, whatever we are doing. And so the important thing is with amyloid, because if you are doing general cardiology, you're going to miss a lot of stuff with the amyloidosis, which you need to do for these patients. And the other thing which we do for the community, which is that we do half-a-day course in which we train all the private offices technologists who are doing the PYP scan to make sure they're doing it right. And also the cardiologists who are reading it come for that half-a-day course in which we make sure they get enough experience that they're reading the scan. That's, I think, the key point, because you're going to get so many false positives. And that's a problem with this study. And you're going to miss some of the studies false negative because it was read wrong. So we make sure that the studies which are done right in the community. And then when the patient comes in, we make sure that we start the patient not only on just the tafamidis, because we also start them on other treatments. Because we also start, we're going to start some research studies here in which the patients can get a silencer with a stabilizer. So there's no issue of getting approvals for combining the therapy or not. And also with a lot of new therapies which are coming, which are in research, which have excellent promising results, we can combine those for the patients to treat them. So I think if they're being treated at amyloid center, that would be much better for the patient. And what we do is in amyloid center is not only the group of cardiologists, it would be part of neurology would be there who would help with their neuropathy. There'll be a hematologist who will be treating all the AL, because AL amyloidosis, which we did not talk about today, also needs very close monitoring with the cardiologist. And same thing, some of these patients, we will start them on diflunisal who cannot afford, who their copay is that high, 18,000 or 20,000 a year for tafamidis, and they cannot afford it. We'll start them on diflunisal, closely monitor it. So I think there's close monitoring and deciding when to switch them from one to the other, and also when to start them on, I had a lot of patients on doxycycline and TUDCA. So the ones who are not responding. So what we do is we closely monitor them. So what we do is we do their NT-proBNP, we do their pre-albumin, we do their troponin. If there's an increase in NT-proBNP and troponin by 30%, or if the pre-albumin is not increasing with the stabilizer or not decreasing with the silencer, then we'll consider changing their treatment. So all these things I think are important and can be done at an amyloid center than at the general cardiology.
So to summarize, Dr. Bakari mentions that the amyloid center is a really super specialized place where you will be able to collaborate on your patient's management. And this will also provide an opportunity to enroll them into the latest studies, otherwise, or research drugs, which otherwise would not be possible through other scenarios. And also work, I think also I see a commitment from your side, Sabit, that you will train all the cardiologists and other places so that they can excel in their abilities in their nuclear labs and the imaging centers to be able to detect this patient. So basically the community wins from this whole approach. That's the whole. And there's a question that comes which says, is this a disease of age or is it let me read out. Does Dr. Bukhari think that this is purely a disease of age, or that we will find in the future that it is not only a disease of age, but that there is differing penetrance depending upon exposures, clinical, environmental, etc.?
Yeah, that's an excellent question. So there are different types, right? The hereditary type, the one which runs in the family, there are two types. The ones which cause neuropathy occurs at a younger age. The one which causes mixed phenotype is in the middle age, and the one which just causes cardiomyopathy is in the starts at the late age. So the question is excellent. There are a lot of questions about this disease which we don't know. So why some of the patients who have V30 MET mutation get the disease when they are 30 years old? And why some of the patients with the same mutation get the disease when they are 70 years old? We don't know why. Second, we don't know that what causes this disease to be common in men, not in women. Why older white men get wild type amyloidosis, not anyone else? Why is that 95% of the wild type disease is in males, and especially white males? So a lot of questions about this disease which needs to be answered. Second, even the diagnosis which we make with PYP, we don't know how PYP uptake is there. We have this thing that is probably microcalcification, but we really don't know what it is attached to, and why certain amyloidosis, which is long fiber mutation amyloidosis, does not have any PYP uptake. So there are a lot of questions about this disease which needs answers.
Yes, and I'm also, Sabi, looking forward to working with you, because there are a lot of AI tools which are going to be becoming very active in mining the ECGs and the echoes to develop. Already there are a couple of papers I've seen in Nature Communications, one from Rahul Dev and colleagues, where they were able to look at the echo patterns of using deep learning, and there was one in JAMA Cardiology. So there will be assistance to be able to figure these people in their electronic medical record. I think you've also developed some form of algorithm to search these patients in the electronic medical record. So a lot of research potential and lots of applicability. I think we're up by 10 more minutes beyond our time. So I think we'll continue this discussion. I think Dr. Bukhari is here. He's going to be in the midst of all of you. Feel free to come and meet him. This month is going to be for all of you to be able to get to know him. And next month onwards, whenever we start the Amyloid Center, we'll make those announcements, but a lot of excitement to build up in the near future. Thank you, everyone. Thanks, Dinesh, and thanks, Daniel, for joining in, and Sabi for such a great talk.
Thank you very much. Thank you.
Good night. Thank you.